from Lebanon. And today I'm going to talk about optimizing the digital workflows in full arch edentulous implant rehabilitations. I'm a periodontist. I have a private practice called Dentist Studio in Byblos, Lebanon. I'm also instructor at the Craniofacial Research Laboratory and Digital Dentistry Department at the St. Joseph University of Beirut. I come from Batroun, a coastal town in Lebanon, known for its beautiful sea, water sports, and nearby mountains. These elements, which I love, are a big part of my life, and I do my best to pass on this passion for nature to my children. Since my childhood, I had also deep passion for technology, and during my residency, I discovered digital implantology, which was a perfect blend of my interest in technology and my dental career. However, with practice, I discovered that the guided surgery process is not that simple and requires a rather steep learning curve. The process depends on several factors that can alter it, and one of these factors is the edentation type. In my previous presentation, I talked about how to improve the full immediate extraction and implantation cases with high radiographic scatter with the use of the digital alignment devices. Today, I'm going to focus on the fully edentulous workflow in digital implantology. So, in fully edentulous patients, we generally have to prepare the patient for the dual scan protocol. And if the patient doesn't have a previous denture, we have to fabricate a new one. And that requires all those clinical and lab steps in order to do it. And finally, add those radio-opaque markers that will be used for the superimposition. And following this, we'll have to do 2 CBCT scans with the dual scan protocol. So the second CBCT objective is to create a 3D model of this prosthesis in order to use it as a prosthetic reference and as a support for the guide design inside the software. Now, however, with this technique, in addition to the fact that it requires several steps to do it, it can generate errors while doing the conversion from DICOM to 3D model and might be technique sensitive because it's also dependent on which gray value threshold we select during the segmentation process. And the values of deviation with root mean square can range from 450 microns to more than 1,000 microns. That's why, with the advent of intraoral scanners, several authors have recommended replacing the CBCT conversion of the denture by scanning it extraorally with an intraoral scanner. This approach allows us to skip a step for the second CBCT and increases the accuracy of this conversion to reach approximately 350 microns. While also some other authors stated that they reach around 130 microns accuracy with this technique compared to 397 microns using the CBCT conversion. So now, can we further improve these workflows in fully edentulous patients with the current digital techniques that we have? We will respond to this question with the following case. We have here a case of a fully edentulous patient with dentures supported by locators. The patient is a 73-year-old male with no major health issues. He has 2 fractured upper implants and suffers from periodontal tissue loss around the lower implants. The patient stated that he already underwent several implant surgery and had many previous implant failures. While viewing the panoramic X-ray, we noticed the severely resorbed maxilla with the failed implants and also an advanced pneumatization of the sinuses. For the lower arch, we noticed that we have limited posterior bone height above the nerve and bone defects around the placed implants. It was decided that we start with the removal of the failing implants in the upper jaw, put a temporary upper denture, and wait for the CBCT in order to take decision regarding the lower implants and do the appropriate treatment plan for both jaws. This is the first step of the removal of the upper failed implants. And after the initial healing, we wanted to proceed with the patient preparation for the CBCT scan. The patient had a pre-existing denture, but this denture had a poor tooth configuration, a collapsed vertical dimension of occlusion, and it was non-adapted to the mucosa. So in this case, we had to replace it with a new one in order to use it as a radiological guide. With the presence of intraoral scanners, we decided to simplify the process by scanning the old dentures with the Medit i700 scanner. This is the regular occlusion scan with the initial vertical dimension of the patient. And this is the new byte registration, where we opened a little bit the vertical dimension and registered a new byte scan, so with the corrected vertical dimension. Based on this acquired data, we have separated the interior surface of the prosthesis and fabricated a customized impression tray using a combination of the Medit design and the Blender for Dental software. And then we took regular impressions with those trays, because till now, intraoral scanners are still not efficient in taking the dynamic impression of the peripheral joint and or the soft palate. But in this case, we did not proceed with the traditional way. We scanned the impression that we took with the Medit i700 and inverted it in order to have the jaw models. Those models were aligned to the models from the new byte registration, and like this, we achieved a digital setup with the adjusted vertical dimensions. So this new setup will be used in order to do like the teeth setup for the new denture design. This video shows the design of the denture of the upper jaw. And this is the denture base that was printed. And to the right, the selected physical teeth from the library that were placed and cemented into their indentations in the base. This is the full finished digital denture. Now, in regular cases, depending on what we saw earlier, we will have to scan this denture and add radio-opaque markers to it in order to do the dual scan CBCT protocol. But here, in this case, we don't need to do that because we already have the digital model, so we can skip this part. And based on this digital design, we can modify it in a way to have a place for the radio-opaque markers to be inserted inside it. Like this, we will have two models. The first one is the printed alignment device, or the pad, the device that we will print physically. And the other one is the DAD, the digital alignment device that we will use inside the software for the superimposition because it already holds those markers. Now, depending on the literature, the models that are printed at 45 degrees in the 3D printing slicing software have the lowest manufacturing 3D deviation by comparing it to the initial design. And it is around 86 microns. Now, if we compare it to the previous numbers with the intraoral scanning, we see that this error from the manufacturing is lower than the error of scanning a denture with the intraoral scan. So, in summary, now we will explain the workflow with those different techniques. So, with the CBCT conversion, we have the more steps and more deviation error while digitizing the denture. With the iOS, we have fewer steps and fewer errors than the CBCT conversion. And with the digital alignment devices, it's the opposite way around. So we have the digital design, but we are fabricating the physical device that we will take the CBCT with it. And it seems that the accuracy is around 100 microns. So that seems for me the best option to go with. Those are the printed alignment devices in the pre-4 slicing software. And the alignment devices printed, and then we bonded the radio-opaque markers of flowable composite in their indentation sites. This is now a comparison between the digital and the physical version of the digital alignment devices. And now, with this technique, we only have to do one single CBCT scan because we already have the digital alignment device. So the DAD will be aligned to the CBCT using the radio-opaque markers. And later, so after we align this digital alignment device to the CBCT, all the ancillary models and floating models that are already aligned to this digital alignment device, like the jaw model and the bone segmentation, can be automatically aligned to it. So the next step now was the assessment of the previously placed implants. As we see, the implants placed inside 33 presents a bone defect, but its position is a little bit outside the bone envelope, making bone grafting in this region inadvisable. So it was decided to keep it, but to disinfect it and polish the buccal surface of the implant. But for the other implant, it had a contained defect where we could potentially gain some bone if we graft the site. The implant simulation was done in the R2Gate software based on the available bone and prosthetic reference, and it was decided to add 4 more implants and do an immediate loading on all implants except implant number 46 because it needed a GBR and it was also a short implant. So those are the cross sections of the implants to be placed and the corresponding digital eye report for each of them showing an adequate bone quality for immediate loading. In our treatment plan, we wanted to do this case-guided, but with a flap approach, because we wanted to treat our old implants, to do a GBR on the tooth on the implant number 46, and because we also had a proximity with the anatomical structure, so it would be safer to do it with a flap. So we decided to do a new guide design that can accommodate a flap without having to be bone supported in order to reduce the post-operative morbidity from extensive flap reflection. So this guide features 2 sections. One section that is highlighted in blue that will be in direct contact of the mucosa with the mucosa to easily position the guide, and this region is located outside our incision area. In red, we have another section with a 3 mm spacing from the mucosa and corresponds to the region where we have to open a flap. So if we take a section on part of this guide, it's a cross section, we see that on its periphery, it's touching the mucosa, but in the center, it has an offset, which will give room for the mucosa after we make the incision and flap reflection to accommodate this flap inside the guide and not outside it. And this will permit to do an open flap guide without extensive open. We will see now a video showing the surgical procedure. First, we start with the fixation guide, where we fix the pins, and then we switch to the drilling guide, and we pinpoint the locations of the osteotomies in order to make the extent of the incision based on the implant sites. And then we do the flap reflection. We can clean and disinfect the old implants. And then we place the guide again to do the final drilling and to place the implants in a fully guided way. We also designed an immediate fixed prosthesis for the implants, which comes with its own guide to position it correctly in the mouth with the desired position and vertical dimension. This is a copy of the previous denture design, but it's separated into 2 pieces, the PMMA part and the holder part. The PMMA and its holder are placed on top of the mucosa and the temporary cylinders placed inside the holes and relined using composite resin. Like this, the patient will leave our office with a new fixed implant-supported bridge, and this is the temporary restoration 2 weeks after healing. After 3 months of healing, the impressions were taken to fabricate the permanent fixed solutions. In this case, a thimble bridge was designed in a way to have a fixed metal bar, red ceramic, and on top of it, 3 sections of full monolithic zirconia bridges. The tie bases were cemented to the metal bar, and the zirconia crown cemented from the other side, while still having through access if we'd like to remove and place back the bridge later on. This is a panoramic image showing the bone condition 1 year after loading. I also prefer to take intraoral X-rays that shows us more precisely the state of the bone, and here we can see the stability of the bone on the new as well as on the old implants treated more than 2 years after load. We also have to note that the patient was happy with this upper denture and decided not to undergo an upper implant rehabilitation for the moment. And finally, in this case, we have seen many enhancements in the workflow of fully edentulous jaws, including a faster fabrication process of dentures and radiographic guides, the digital alignment devices simplifying the workflow and reducing the steps, an accurate 3D planning using the 3D segmentations and digital eye aiding in the decision-making, surgical guide design optimization to open a flap with less invasive surgery, and finally, We also demonstrated a simple yet efficient way for the immediate temporization technique. And thank you.
Recording stopped.
Thank you, Dr. Nabil. So the judges, any comments?
Thank you very much, Stenilson. Very good lecture. Thank you. Very nice photo. Do you like to do photo during the treatment?
I'm sorry.
Do you like to do photo during the treatment, during the surgery?
Photo?
Yes. Oh, I'm sorry.
Yeah.
Do you hear me
because
now?
I didn't hear.
I said you,
Yeah.
you have a very nice photo.
Thank you. Thank you. Yes, yes, of course. Everything digital, I like.
Everything, every patient, every time during the treatment. Super.
Yes, yes, it's a regular protocol in order to take documentation for all my cases.
Fantastic. Congratulations. Very nice picture.
Thank you. Thank you.
And very nice case.
Thanks. Glad to hear that.
Okay. Okay. So thank you for today. And the result will be announced on 26th of July. So please check our website.
colleagues and friends. I hope everyone had a great time. Thank you, MEGA'MIND and MEGA'MIND for organizing this event and encouraging participation. My name is Majid Shahmoradi, and I am a board-certified periodontist from Isfahan, Iran. My topic today will be the mandibular arch rehabilitation story. I would like to start with an interesting quote from the American writer and humorist Mark Twain. He said, "Adam and Eve had many advantages, but the principal one was that they escaped teething." Colleagues and friends, I hope everyone had a great time. Thank you, MEGA'MIND and MEGA'MIND for organizing this event and encouraging participation. My name is Majid Shahmoradi, and I am a board-certified periodontist from Isfahan. Start with an interesting quote from the American writer and humorist Mark Twain. He said, "Adam and Eve had many advantages, but the principal one was that they escaped teething." Teething could be a challenging process in some people, like my patient. She was a 19-year-old girl, most of whose teeth didn't erupt in the mouth. This led to multiple problems, including chewing and speaking disorders. She didn't have enough confidence and rarely smiles. Her social relationships were limited due to her dental appearance, and she suffered from depression. Let me talk more about her dental history. She was suffering from a genetic disorder which most of her permanent teeth couldn't grow and remain impacted. After consulting with an orthodontist, it was decided to extract the impacted teeth. As you can see here, let me show with the laser point. This is her panoramic before he extracted. And as you can see, her erupted teeth had enamel defects because of amelogenesis imperfecta. The tooth shapes and morphology were abnormal. Her erupted teeth also didn't erupt completely, and they had altered passive eruption. I mean that the gingiva and periodontium were located coronal to CJ. With these short anatomic crowns, restorative procedures could be challenging. This is the baseline for my work. In each quadrant, she only had central and lateral incisors and the first molar. Some deciduous teeth were also in her mouth. In these periapical radiographs, I evaluated the remaining teeth. As you can see here, her interarch spaces were also a big challenge. The vertical distance between the maxilla and the mandible were uneven. On the right side, as you can see, the space is limited for any kind of restoration. On the left side, it is the opposite. As it is shown, her mastication was impaired. She also had very extensive soft tissue scars, as you can see here and there, due to previous surgeries. In this occlusal view, the whole mouth is shown. Let's talk about the mandible. On the right side, the primary teeth C and E are present. The first molar is under the gingiva. On the left side, the primary tooth C is shown, and the first molar is hidden under the gingiva. As you can see, the 4 incisor teeth are present with huge diastema between the central and lateral incisor. And this is the patient periodontal chart. Let's list the risk factors and problems of the patient. Missing teeth in various areas, short clinical crowns in the remaining teeth, impaired tooth enamel, patient highly blind and gummy smile, inappropriate interarch spaces, and inadequate bone volume, poor soft tissue quality with extensive scars, and finally, lack of posterior occlusion. The diagnostic steps were done digitally and also in a conventional ways with my friend, Dr. Sharifi, who is a prosthodontist. Two different treatment plans were proposed. The first one was to extract all the remaining teeth, including the primary and permanent teeth, and full mouth rehabilitation with dental implants. The second treatment plan was extracting all the studious teeth and crown lengthening of the remaining permanent teeth, and finally, implant placement in the remaining edentulous regions. So why we prefer the second treatment plan? Because the natural tooth values more than the implant. They have better proprioception sense, which results in more controlled masticatory forces. In this case, more implants requires more augmentation procedures. So maintaining her teeth in her mouth is really less invasive option. As you can see, we choose the treatment number 2, and here are the details of our treatment planning. As you can see, the surgical phase consisted of extraction of primary teeth, crown lengthening of incisors and first molar, and bone augmentation and implant placement in the premolar regions. Let's focus on the mandibular arch. In the first step, primary teeth were extracted and crown lengthening for the permanent teeth were performed. In this picture, you can see the baseline. Look at the incisors and look at the incisions in the second picture. As you can see, at least the incisions were planned to maintain at least 3 millimeters of keratinized gingiva for each teeth. And here is the 4-week post-op after the surgery. The result of first step helps us to reevaluate our treatment planning again. In the posterior regions, the first molars were hidden under the gingiva. On the right side, primary teeth C and E were present. I extracted the deciduous teeth and crown length the first molar. Here is the baseline and the result of first step of our surgery. The tooth crown height were increased for restorative phase, and the molars are ready for the rest of treatment. Also, the interarch space is increased. And here you can see the result of this step from the occlusal view. The first molars were placed under the gingiva, and after the crown lengthening, they're revealed. You can see them here. So after that, in the second step of surgical phase, the ridge augmentation and implant placement were planned. Let's look at the amount of bone in the premolar regions. The bone height is enough, but what about the width of the bone? On the right side, please notice the section number 10. The bone width is around 4 millimeters. On the left side, please notice the section number 20 to 24. The bone width is around 4 millimeters. So in order to place implants, we need to horizontally augment the ridge. For horizontal ridge augmentation, there are many options. One of them is GBR techniques, particularly sausage technique, which was introduced by Professor Ishtvan Orban. The other possible option is bone block technique, including the split bone block, which was introduced by Professor Fuad Khoury. And the third one is ridge split technique, which was introduced initially by Dr. Tatum and Summers. For the following reasons, I choose the ridge split technique here. First, the patient's entire course of treatment was quite lengthy. By using the ridge split technique, it will be shorter than the others. The second reason was that additional autogenous bone and different donor site was required for GBR or bone block, but not for the ridge split. This would result in lower patient morbidity. And ridge splitting allows us to convert a single wall defect into an intra-bony defect that resembles a socket. This kind of bone morphology is easier to augment and more predictable. I should say that we needed to augment numerous regions in this patient. All 4 quadrants of the mandible and maxilla required bone augmentation, and her mouth had a limited supply of bone that could be used as donor site. We use a lot of autogenous bone for the maxilla because of its defect morphology. So ridge splitting was therefore a wise choice for the mandible. I want to introduce you a valuable book, Essential Techniques of Alveolar Bone Augmentation in Implant Dentistry, a surgical manual. The ridge split technique is explained in this book beautifully. Let me now briefly go over the 2-stage ridge split procedure. The alveolar ridge is split horizontally in this procedure to create a pedicle osteoperiostal vascularized flap. The primary factor in maintaining the vitality of the mobilized jawbone segment is vascularization. A stage alveolar ridge split is often performed in the mandible. Why? Because the high density of the bone. A split expansion is done in the stage 2 after corticotomy is done in stage 1. And afterward, a particulate grafting material is inserted as an interpositional inlay graft in the space between the cortical bony plates. I will explain more about this in the upcoming slides. As you can see here, in order to choose the proper technique, Tolstoy's classification of the alveolar ridge widths can help us, which is in the book that I introduced. The ridge morphology and defect widths make it a good candidate for ridge split according to this classification. Our patient has somehow near 3 to 5 millimeters ridge widths, and also the morphology of the ridge was like the class 3 and 4 of this classification. And as you can see, there are ideal ridges for ridge split technique. And of course, in the class 3, we can place the implants in the same stage as the augmentation. So it really shortens the treatment period. So corticotomy is a superficial osteotomy when a drill or piezo tip is cutting only through the cortical portion of the bone without touching the medullary portion. I'm introducing the 2-stage ridge split, and I will show more about it. The goal of corticotomy is to weaken a dense, mineralized, rigid cortical layer of the bone in the area. As you can see, the corticotomy is only here in the cortical bones, and it doesn't extend through the medullary bones. Let's see the procedure on the right side. In the picture, stage 1 of the ridge split procedure in my patient is demonstrated. The crestal, apical, mesiovertical, and distal vertical corticotomy is performed here. And in the second stage of this technique, which is done 4 to 5 weeks after the stage 1, we will split that bone. The bone split that follows should be initiated with osteotomes at the center of the crest, and it progressed deep inside the bone. In this phase, after splitting the bone, the implants were placed, and the surgical guide was used in order to place the implants in a prosthetically driven manner. Here you can see the outline of my procedure. Let's look at the whole procedure from the occlusal view. As you can see here, this is the baseline after we perform the crown lengthening. And in this picture, the ridge split and expansion are accomplished. The next step is particulate bone grafting that is packed from the bottom of the lesion into the created gap, similar to ridge preservation procedure. Afterward, I place the membrane on the top of the ridge, and as you can see here, this is 4 months after the surgery and before implant exposures. I did the same way for the left side. In the first stage, I raised a full thickness flap with 2 vertical incisions. 4 osteotomies were made, and all of them are with limited depths in the cortical part of the bone. This is the outline of my osteotomies. After that, I will suture the lesion, and after 4 weeks, I again open that. And the second stage will be done. This stage starts with a full thickness through the crestal and 2 short vertical releasing incisions. And the goal is to open just the crestal corticotomy and to keep periostal vascularization on the buccal side completely intact. After a split and expansion, after that the splitting and expansion were done, you can see that we place the implants, and the following step is particulate bone grafting, which was done by the xenograft. Let's see the posterior segment results. Here is the baseline, as you can see, and 6 months post-op results. The ridge widths increased. The soft tissue condition is also in a good way. There is good amount of keratinized mucosa around the implants, which ensures long-term stability and health of implants. And this is the overall journey, as you can see. I show the entire procedure from the occlusal view. This is the baseline after the CL and after the implant placement and implant exposures, and after the restorations. And this is the intraoral condition from the frontal view. I want to thank my prosthodontist colleague, Dr. Mohammad Sharifi, for the prosthetic phase. And this is 1-year follow-up, as you can see. In this patient, I prefer to maintain the natural tooth. I try to solve her problem with the most simple solution, which ensures long-term and secure results. Now, the final remarks. Accurate treatment planning is critical to finding the right treatment plans. And before deciding the final treatment plan, search for all possible options may be the best one. Maybe the best treatment plan is not the first one. And in complicated cases, multidisciplinary approach engaging various specialties is a must before starting the treatment to the end. And preserving a patient's natural teeth should be a priority whenever possible. I want to wrap up my presentation with a quote from Sutherland. It's very satisfying to take a problem we thought difficult and find a simple solution. The best solutions are always simple. This is my city, Isfahan. Thank you for your attention, and thank you.
Recording stopped.
Recording has stopped.
Okay, thank you, doctor. So our judges, any comments?
I have one question. How old is the patient?
At the beginning of the treatment, she was 19 years old.
How much, sir? How old?
19.
18.
Yeah.
But 19 is, I think it's a little bit too early for dental treatment, for dental implant treatment.
Usually after the 18 years of old, most of job growth is done and completed. And so we started it because she wanted to go to the university, and she had some major problems. But after the 18-year-old, we can do it, I think.
Actually, it's not so sure about the 18 years old that the skeletal base stops to grow, because many literature shows that usually the bone proceeds to grow until 21 years old.
Yes.
So it's quite questionable, but okay, we have chosen.
Yeah. For that reason, I prefer to maintain his anterior teeth, and we just did the implant therapy in premolar regions.
It was very difficult treatment. Congratulations, doctor.
Thank you.
Okay.
I have
Thank you,
one
doctor.
Can I see my time somewhere?
Yes, yes, of course, of course.
Okay. So, hello everyone. Welcome to my lecture. I'm your host, Marwan El Mobadder. I am happy to be invited to the next level of the 2024 edition of MEGA'MIND. Today, I'm going to talk about immediate implantation and infected sites, and I will try to make it worth your while. First, just quickly, I will remind you that in the National League, I've talked about peri-implantitis. So I discussed that it is important not only to place a perfect implant, but the long-term stability is always important. So we concluded that it is very important to do what's known as supportive peri-implant care. Today, I'm going to talk actually about day zero, so about placing a perfect implant in the perfect conditions in infected sites, so in this special site. Now, since we have only 15 minutes, I think that all of us here knows the definitions, so I will skip the definition of immediate implant placement and infected sites, and I will move directly to the literature, what I think is very compelling. One of the reasons why I have chosen this topic is that, as you can see in the literature, there is until today somehow a controversy. So some authors, some articles are against immediate implantation in infected sites, and some authors are with. The authors that are against, usually they will argue that it will compromise osseointegration, there is a tendency toward implant failure, retrograde peri-implantitis, etc. And the authors that are with says that there is statistically no significant difference in the long-term success, and if doing it properly, we will actually have a very predictable results. It's always interesting to see the guidelines. So going through international guidelines, we can notice that, for example, the European Federation of Periodontology and the American Academy of Periodontology doesn't have any recommendations or whatsoever. The European Association for Osseointegration is against doing immediate implantation in infected sites when it is an acute infection. And the ITI is with if it is a chronic periapical infection. Here we can ask a question: what about periapical granulomas? What about periodontal abscess? So it's missing. They are talking only about periapical infection. So maybe the first conclusion of my presentation is that until today, there is a lack of gold standard protocol when it comes to immediate implantation in infected sites. So clinical studies are important, the guidelines are important, but I think what will actually give us a very accurate insight and what is very important to see in infected sites is histological studies, because clinical studies maybe will give us an idea on the long-term stability, etc., but we don't really know what about the percentage of BIC, bone to implant contact, what about this nature of this osseointegration, the quality of it. So without further ado, let's move to histological studies quickly. A study by Shang et al. Compared the 3 different sites. One site, no infection, so it is the control group. They did immediate implantation, of course, on dogs. This is an histological study. Another site with infection without membrane, and the third experimental group with infection, they did immediate implantation, but they've placed a PTFE membrane. So they found after 3 months that there was a statistically significant decrease in bone to implant contact measured by percentage. So we can conclude that, and based on histological studies, that immediate implantation in infected sites will significantly decrease BIC. And these findings were also confirmed by other studies, such as a study by Novaes et al. So the second conclusion of my short lecture today is that the percentage of BIC will decrease statistically significantly in infected sites. After this very brief introduction, so we know that there is no gold standard approach. There is somehow a controversy in literature, and histologically we've seen that there is a decrease in BIC. So do we perform or not immediate implantation in infected sites? In this lecture, I've decided that we want to perform immediate in infected sites, but I will try to advocate, so maybe the aim of my presentation is to try to advocate an optimal approach when we want to do so. Of course, I'm not pretending that I'm giving guidelines. Further investigations are very important. We need further studies. But in case we want to do immediate implantation in infected sites, let's propose an ideal approach. This ideal approach will be determined. I tried to simplify things to divide this optimal approach into 5 factors. The first factor will be implant selection. And for implant selection, let's see why I have chosen any ridge or a blue diamond from MEGA'MIND. First of all, because of the knife thread surface. Based on studies, this knife thread surface increased significantly the BIC. And since we are dealing with a compensation in BIC, it's a good idea to use knife threads. Also, because of the X-speed surface treatment, also based on studies, we can see that the X-speed treatment, so this rich in ion calcium composition, will accelerate the mineralization to create hydroxyapatitis. And finally, if I want really to suggest an optimal approach, I will suggest to use the plasma X motion from MEGA'MIND, because based on a recent study conducted by Makari et al., we can see that after using the plasma X, there is a significant increase in BIC. So again, we are trying to compensate this low BIC that we can have from doing immediate implantation in infected sites. So back to my 5 criteria. The first one, implant selection. Now we know what to choose. The second criteria, and since I have 15 minutes, I will go quick for the other criteria, is to give prophylactic antibiotics, also based on studies, is to do a very thorough mechanical debridement after extraction, and to control as much as possible all the patient-related factors. And here we can remember my first presentation. In the first presentation, I've discussed that we need to control not only the day of placing the implant, the oral hygiene instructions must be controlled, etc., the hygiene of the patient, and we saw how important is that. So the final criteria that I can suggest is to enhance local disinfection. And in enhancing local disinfection after mechanical debridement, I would suggest the using of photoactivated disinfection. So briefly, I will base, so everything that I'm going to say now will be based on a study that we've published. We've published this study on in deep periodontal pockets, but we saw using photoactivated disinfection that we can enhance significantly the reduction, so the disinfection, the reduction of total bacterial count, and most importantly, and I will discuss this, we can have a reduction of the periodontopathogens, the pathogens that are directly linked to peri-implantitis, periodontitis, etc. So very briefly, photoactivated disinfection, also known as photodynamic therapy, is the use of a photosensitizer, a molecule that will go and fix to specific bacteria or targeted tissue, depending on the protocol that we are doing. And after fixing to on these pathogens, we can activate the photosensitizer with a light source, and this will result in a very excessive reactive oxygen species liberation. So we will have a very important disinfection. Disinfection that is more important than using simply peroxide hydrogen and etc. So rationality of using photoactivated disinfection, we are dealing with an infected site. It is always a good idea, but I have to say that we need further investigations, and this is a very interesting area to investigate. We are increasing disinfection, so it's a good idea to use it after and not a replacement after mechanical debridement. It will compensate the limitations of the mechanical debridement. Mechanically, we cannot remove what we cannot touch, but chemically and with light, we will have a deep tissue penetration. We did a PCR test, real-time PCR test, and we saw that this specific approach not only decreases the total bacterial count, by the way, this is in Polish, so it's good, I have a chance. We saw that not only it decreases the total bacterial count, but it decreases the count of the specific periodontopathogens, such as Porphyromonas gingivalis, Treponema denticola, etc. For this patient, he didn't have aggregate bacterial actinomycetam comitant. So this is the protocol. Of course, calculations of the parameters were made based on studies, and it is very sensitive if we want to have optimal approach. We don't have time to talk about this. The idea is after mechanical debridement to use photosensitizer, wait for almost 1 minute, activate the photosensitizer with a light, and you have to do exactly the same protocol 3 times, and then you can place your implant. So the conclusion of my presentation is these 5 factors to enhance to enhance our immediate implantation in infected sites. Use any rich or blue diamond because of the knife threads, the XP surface treatment, and try to use the plasma XP if you have it in your clinic. Give antibiotic prophylactic antibiotics, do a very good thorough mechanical debridement, then do photoactivated disinfection, and finally try to control the patient-related factors. With everything that we have said, we can conclude in this small case report, this is a patient with infected site. Otherwise, he is a healthy patient. He is a smoker. His chief complaint was just discomfort, and he wanted to do a rehabilitation. I've read the literature, and after proposing this treatment protocol, I've applied in details this treatment protocol. First step is to give prophylactic antibiotics, atraumatic extraction, manual and ultrasonic mechanical debridement, then to use toluene chloride as a photosensitizer in this case, and then after a wait of 1 to 1.5 minutes, activate the toluene chloride with a 635 nanometer wavelength. Of course, the choice of photosensitizer and the choice of the wavelength of the light must be really studied, because if you want to have a positive results. And finally, to put an implant, so implant selection. These were the implants. This is the implant specification. This is immediately after treatment. And this is a recent case. This is 2 months after treatment. So if we want to have some key takeaways of this very small presentation, first of all, until today, there is no standard approach for immediate implantation in infected sites. So we need to try to find approaches, and this is why this topic is important. There is somehow a controversy in literature. Not all studies agrees. Then we saw from very important histological studies that the bone-to-implant contact decreases significantly. And I've searched the literature in order to try to find what is the minimal number of or percentage of BIC that we can consider acceptable. And I couldn't find a number that we all agree on. So for example, 30% is acceptable after 3 months. So it is a good strategy to always try as much as possible to increase BIC. And this is why I will advocate to use knife threads, X-speed surface, and the plasma X from MEGA'MIND. And finally, it is a good idea, of course, a good idea based on scientific evidence, to use photoactivated disinfection in order to enhance local disinfection in the infected site. So that's my very small lecture. And since I have time, I've written my biography. Please, if you have any questions, I'm ready to answer all of them.
Recording stopped.
Thank you for your presentation. So, judges, any comments?
I have one question. Do you really believe that the photodynamic therapy and debridement had a real great influence on just a minute, sorry.
On disinfection? Do I believe that it has a I do believe 100% because I saw exactly this disinfection in the deep periodontal pockets, and deep periodontal pockets are not really different from sites with infection. And also, I said that we need to do further investigations. This is interesting, but we need to do further investigations. And also, we have to remember that mechanical debridement alone has some limitations. So yes, we need some chemical disinfection. Personally, I do believe, but we need studies exactly in infected sites. Other questions?
If I can, great topic, congratulations, and thank you very much for Polish accent.
Thank
in
you.
your-
Thank you so much.
Okay.
Thank you so much.
Thank you for your presentation.
I'm Dr. Bachar Husseini, oral surgeon and implantologist, and today we will discuss our topic, management of the anterior dentition failure via the Hadrick technique. First of all, I would like to introduce my country, Lebanon. This small country located in the heart of Middle East, small by its size, but rich with its culture and history. That's my clinic, the Dental Square Clinic, located in Beirut, the heart of Lebanon. This clinic is specialized in oral surgery and implantology. From my first year on the university, I was known for my love and passion in histology and clinical application of different grafting surgeries. Our case today is Wael. He's a 62 years old male with controlled hypertension, previous smoker. He came to my clinic saying, "Doctor, I cannot eat normally. My front upper teeth are mobile, and I lost like 5 kilograms." The clinical examination revealed some generalized recession, periodontal pockets, and grade 2 teeth mobility, along with some abstraction marks on the mandibular teeth, which suggest some occlusal dysfunction. The periodontal exam revealed some deep pockets in the upper maxilla up to 5 millimeters, which is borderline surgery, and some recession ranging between -1 and -3 millimeters. The radiographic showed generalized bone loss, deeply decayed left premolars that needs to be extracted, and ill-fitted ceremometallic bridge. The wisdom teeth could be left alone sleeping. So, how can I help Wael to eat back in a normal way? My first approach was a bit conservative. I decided to perform the periodontal therapy, which means some deep scaling and mechanical and chemical deep scaling, and then infrabony defect surgery. And when the periodontium is stable, I would go to endodontic treatment and zirconia crowns. I started with a normal deep scaling, probing, showing those 6 millimeters and 5 millimeters mechanical debridement using Curat's chemical, and biological using hyaluronic acid, cross-linked hyaluronic acid. As for the anterior teeth, I did a papilla preservation flap, removed the granuloma, grafted the site using an organic bovine material with prosthetic hyaluronic acid. And of course, the teeth were splinted in a way to prevent any occlusion on them. So why am I using this hyaluronic acid and I keep using it in every surgery? Well, to understand it, hyaluronic acid can interact in the 4 phases of wound healing: hemostasis by attacking blood and stabilize coagulum, inflammation, reducing pain and swelling, and of course, proliferation, which is the most important one for me, enhance angiogenesis and attracts mesenchymal cells, the needed cells for regeneration. However, we have pitfalls always. 2 months later, the patient called me. Doctor, things are not going well. My teeth are moving. I don't want any removable prosthesis. Let's go for implants. Before jumping to implants, I must remember that we have teeth mobility, which means bone loss, lack of keratinized tissue, which means my implants will not be 100% safe, and moderate smile line. It's a complex case. How should I treat this case? We have 2 approaches. Either a traditional way, when we extract, wait for soft tissue healing, then guided bone regeneration, followed by implant placement and soft tissue grafting, and finally the prosthesis. It can take up to 10 to 12 months. Or the techniques that I developed, that I repeat, this technique doesn't work every time. It's like really strict for the patient, for patient selection. It's immediate implantation and temporization, contour augmentation, not a GBR, and soft tissue grafting, all in one. And at 4 months, we can go with a prosthodontic workflow and clown delivery. Before jumping to anything, we must just look and observe our CBCT slices. You can see here, we have enough bone apically to place our implants immediately. However, we have some vertical deficiency. How should we treat this one? First of all, my implant was the MEGA'MIND Continental for a reason. Since I'm placing my implant immediately, I wanted to obtain a high stability and preserve it during the healing phase. That's why the NLH, due to its microgeometry and of course this calcium incorporated XP surface, as you can see here in this graph. Okay, for the implant, but where should I place my implants? I found this lovely article by Francesca Velati and Dr. Urs Belzer. They proposed and discussed different clinical scenarios, and the best one was to place 2 implants, regular implants, at the lateral incisor sites. In this way, we can, of course, manipulate soft tissues in order to create a beautiful smile and a easily cleanable prosthesis. But mechanically, it's okay. What about mechanically? Well, to answer this question, another article by Dr. Correa et al. It's a finite element analysis study. They showed that implants placed at the lateral incisor sites have the lowest strain on bone and even crowns and implants, which means the optimal solution is to place 2 implants at the lateral site. Surgical planning here, you can see the implants in the bony envelope. And now for the surgery. I raise the flap. We can see here clearly the non-integrated bone particles. My failure was here, of course. After removing my failure, I stumbled upon a missing buccal plate, as you can see here, and those bony peaks. If I was going to do the traditional technique, my maximum bone level would be those bony peaks, unless I want to extract those canines. That's why I didn't do the traditional one. I placed my implants, but before placing them, I used my Plasma X motion machine, which is a machine that removes every carbon atoms on implants and even promote better bone formation. This picture was taken, but the implant picture was taken at my clinic, and those histology by my professor, Christian Bakari. As you can see, the histology, better bone formation at 4 weeks. Now, implant placed, we have jumping gap 2 millimeters, We have this deficient socket that needs contour augmentation and socket preservation. However, it's okay. Well, we have a deal concerning the bone, but what about the soft tissue? It's a large area to cover. We have two options. Either the autogenous, which is the gold standard without any negotiation, but I will stumble with a single problem, the post-operative pain. I would have to harvest half of the palate of the patient to restore this one. That's why I decided to use a xenogenic bone substitute, soft tissue substitute, which is the MEGA'MIND. It's an acellular xenogenic collagen matrix made of collagen type 1 and type 3. Isn't that the ingredients of a normal GBR collagen membrane? Plus, if you can look here at this microscopic picture, it's a dense network of collagen, which means it will inhibit for sure the penetration of epithelial cells and even maybe not even bacteria. That's why I decided to use the MEGA'MIND as a GBR membrane and as well as a soft tissue augmentation, following the biological concept of compartmentation. Upper will be soft tissue and lower will be protecting the hard tissue. As for the bone, I did a mix of 50-50 an organic bovine bone material, which is only osteoconductive, and allograft DFTBA, which is osteoinductive. All of them were mixed again with hyaluronic acid. I know I talked about hyaluronic acid, but let me explain something. That's an article. It's a split mouse pilot study performed by me and my team, my colleague, Dr. Nabil Ghosn. It was on 14 patients. We studied the resorption rate, volumetric CBCT, volumetric resorption rate between test groups that received bovine bone material with hyaluronic acid and normal control that received only xenografts. We can see here show us very little resorption in the test site. It's good for the quantity. What about quality? My histology clearly shows that we have better bone formation. The de novo bone formation was 59.61% at 4 months. That's why I like to use this one. Okay for the bone. What about the soft tissue? How should I place this matrix if I want to temporizate my implants? I will introduce for you the hat-trick technique. It's a modification of soft tissue grafting and bioactivating it. I will start to the Pontic side. I did this figure. Basically, I will create some bevels on the collagen matrix, fix it with some bone tacks, inject hyaluronic acid in the middle, and furthermore stabilize it with periosteal sutures. It's on the Pontic side. And it was a split mouse too. We can see here that A, which is the test side, and B, which is the control side, I had a better volume gain. It's normal since hyaluronic acid absorbs water. It's known. But what about histology? And I was really impressed. The stain of hematoxylin eosine showed very little remaining particles in comparing to the control, if you follow the white arrows. As for the picoserious red stain, which indicates the collagen network, we can see here very organized collagen network, in contrast with the control, where we have some thick collagen fibers, indicating possibly a fibrosis or a slow remodeling. Back to my case. The modified hat-trick technique was just to place my implant and create some punch in order to place my provision. It's a simple technique. Here we can see the exposed MEGA'MIND and the provisionals. I'm really sorry for those provisionals, but my lab provisionals broke, and that's what an neurosurgeon can give you as a static work. The site after healing, we can see here the volume maintaining, and if we look closer, the emerging profile respected the Gomez-Meda-Ramon concepts of emerging profile design, the EBC design. As for the crowns, I decided to use a zirconia crowns layered with Emax. And of course, the Pontex bullet shape for an easy cleaning. Crown delivery here. Well, he's happy finally, he is eating, everything is good for him. 1 year follow-up with the crowns in place. We can see here clearly the papillas, even this distance is created by the patient itself due to his habit of cleaning using proxy brush. 1 year follow-up X-ray, we can see here the stable bone over the implant shoulder and even the CBCT. But do you know something? I will tell you a little story. After 1 year, what I have recognized that I made some mistakes in this case. One of it is that I didn't call for a digitally guided implant placement. I didn't call my friend Dr. Nabil Ghosn to make an incredible guide like he does in his cases. It would have like outbounded my results. Before finishing, I would like to say a quote from Professor Marie Curie: nothing in life is to be feared, it's only to be understood. Now is the time to understand more so that we fear less. Thank you from Lebanon with love.
Recording stopped.
Okay, thank you for your presentation. The judges, any comments?
Thank you very much. It's very good result what you got. The question is, would you try not to mix the bone substitute material with allogenic bone?
Look, it's an important question. I tried it. Honestly, I will say I tried to do it. It's a very good volume maintaining. But since I had this defect, defect of the socket of the central incisor here, as you can see, it may not work perfectly. That's the only reason why I introduced the allograft. You see, it preserves the volume of the socket. That's it. But don't the xenografts. But the allograft will help in a little bit in adding a value, osteoinductive value.
Okay. Good. Okay. And the question is, if you would not use the any membrane at all, would you get the same result?
I don't think so. I don't think so at all. I have some cases where I didn't use any membrane. I have, of course, I will have fibrointegration of those xenografts. And even more, I would have what is called nowadays, I read an article 2 days ago, perigraphititis. It's a new term. I didn't know about it. It's the graft particles would be fibrointegrated and easily infected in case of any bacterial invasion.
Okay, well, thank you very much.
You're welcome.
I have a question. Can you say me how long do you do this technique? How many years?
How long? It's like 2 years, and I have like more than 20 patients. In fact, this case will be part of an article, which is a modified Hattic Part B technique.
Thank you.
You're welcome. But as I said,
Dr. Bachar, just it's my recommendation just to you.
So good afternoon, everyone. Like we already said, I'm aware that everyone has been at this for some time, so we'll make this as pleasant as possible. I'd like to thank all of you for taking our time out of your practices and days to listen to a myriad of lectures for hours and hours. I really appreciate it, and it's a great honor to be through to the continental round of the MEGA'MIND. For those of you that I haven't had the privilege of meeting, my name is Rhoodie Garrana, and I'm a periodontist from Johannesburg, South Africa. And it's a great honor to share what we do here with the rest of the world. So what I'd like to talk to you about today is predictability and reproducibility. With regards to implant dentistry and the protocols that we use in our practice. A large part of what we do depends on the predictability and reproducibility. It doesn't help if there's a technique or a procedure that works 1 in every 10 cases. I want to be able to carry out a case predictably and make it reproducible for every patient in the practice. To demonstrate the predictability and reproducibility, I'd like to share with you a case that I've been working on. It was a middle-aged female that presented to my office with a tooth 1-1 that exhibited radiographic signs of external inflammatory resorption, cervical resorption on the tooth. When she came, she was devastated. She has a relatively virgin dentition. She's got a few restorations here and there, but she was devastated at the fact that she had external cervical resorption on this tooth, and we had to come up with a game plan with regards to what we could offer her in terms of management. So she has a thin biotype and triangular shaped teeth, which makes this a challenging case when considering implants in the anterior aesthetic zone. I classified her as a class 1B radial tooth position, according to Gluckman's CBCT analysis of radial root positions. And this is significant because I find it's one of the most important things we can do when we start assessing cases, is try and understand the field that we're working in before we blindly apply treatment protocols to these patients. And when considering an implant case, if we were going to place an implant in this case, when considering the radial tooth position, we need to understand that for an immediate situation, less than 50% of the implant will be embedded in native bone. If we were going to look at an immediate load type of situation, and less than 50% of bone being around the implant at the time of placement is not ideal. If you look at the work done by Joseph Kahn and the likes, we would like at least 50% of the implant to be embedded in native bone when considering an immediate situation. Obviously, Ostel readings taken at the time of placement are a decisive factor, but this is something that's certainly going to play on my mind. So we're already starting off on a little bit of a back foot if we were looking at removing the tooth and placing an implant. Because of the thin biotype, I've got several options available to me. Do we go with a socket shield? Do we extract the tooth in its entirety and do dual zone technique as the Swiss recommend? Do we go with dual zone and the sandwich technique as the Swiss recommend, or do we go with dual zone therapy? Socket shield, obviously a firm favorite of mine in cases where we want to maintain the surrounding tissues. So I decided to remove the crown using a very, very thin fissure burst applied in my socket shield armamentarium, making sure that we are not damaging the soft tissue, applying slight lateral force on the crown. And so I can remove the crown at the level of the gingiva so I can get a good look at what's happening. And we can see clear signs of the resorptive tissue and the granulation tissue inside the canal. Not a lot of sound tooth structure left on the inside of that tooth. I then continue with my fissure burrs in my kit to section the tooth, and I'm trying to see if I've got enough sound tooth structure here to perform a socket shield. Obviously using radiographs to assess my depth and my alignment so that I'm not off, but I want to see if I can remove and keep enough tooth structure and remove enough of the palatal root to get an effective shield in place. So this was us having removed the palatal root segment, and you can see the destruction of the tooth structures quite significant when you're looking at it from this angle. And we have a retained buccal root left in place. We then go through the protocol, reducing the root and thinning out the root and giving it some curvature to make space for the implant. We want to create as much space as possible between the implant and the shield. It was at this time, though, that I decided that I wasn't going to have enough bone to anchor the implant into successfully. So I changed my plan during surgery, and I grafted the socket with a Glocker technique, as was described by Marcus Glocker in 2014 as a form of ridge preservation. And I think that the benefit of this is largely underreported and underrated, because, you know, if you can have a fully healed ridge and come back and place the implant into a healed ridge, and the implant is circumferentially encased in bone, the chances of success are much higher, especially when you don't have a lot of palatal bone to engage that implant into. So I grafted the case and I let it heal up. The problem was, how do I temporize this patient? Because the benefits of immediate placement and immediate load allows me to preserve the soft tissue architecture and provide some sort of a provisional for the patient during the healing period. In the case where we're not going to be placing immediately, we need some type of a solution that we can give the patient whilst we are awaiting healing. So I took the tooth that we had sectioned off, and I added some composite, and I used the pencil to mark off where I wanted my zenith point to be. And these photos are very rough of when I first started. And then I bonded the crown back to the adjacent teeth in place at the ideal position, highly polished composite to stimulate hemidesmosomal attachment to that area. Is it a perfect provisional? No, but I believe that a removable partial denture would destroy the soft tissue architecture there over time. It's not ideal. This is the best I could give them in this situation. And so making sure to copy the architecture of the soft tissue from the contralateral side. 4 months later, we opened up the site, and we are pleased to see that there is solid bone, vascular bone in that area. We can see the shield, and we can see bone on the buccal part of that shield. So we've achieved a functional ankylosis of that shield, and we've maintained 100% of the volume that we set out to maintain. When raising that flap, I make sure that it's low trauma as possible. I then placed a MEGA'MIND AnyRidge implant into that site, suturing the papilla together. And now, at this stage, my ostal reading is a lot higher, and having the implant encased in bone, I've got a much better chance of success. And so I can think about doing an immediate load restoration at this stage. At this point, it's important to look at the work done by Ramon Gomez Meda and his team, looking at what they call the aesthetic biological contour of a tooth, where we have the aesthetic zone, the biologic zone, and connective tissue zone. Hansu spoke about this previously, where she talks about critical and subcritical contours, and it's effectively the same principle, except a more up-to-date paper where they talk about the aesthetic and the biologic zone. So the aesthetic zone responsible for the gingival margin and where the gingival margin is going to sit. And this is the 1 millimeter of prosthetics or prosthesis that is sitting below the gingiva. And then once you get to the biologic zone, having it as concave as possible to allow for the infill of biologic tissue rather than prosthetics. And then the connective tissue zone, obviously also important, adding to that insulating cuff of tissue that is going to ultimately protect the implant through its life. So my lab is already very au fait with developing provisional restorations according to this protocol. We want to make sure that we adhere to these zones so that we can get optimal soft tissue healing, and we can control the soft tissue where we want it to be. After healing with the provisional, we can see clearly here, according to Ramon Gomez Meda's paper, we can see the aesthetic zone, the biological zone, and the connective tissue zone very nicely. And this kind of just reiterates that we've achieved what we wanted to. If you have a look at the time of placement of the provisional, which is 24 hours after implant placement, if we use a reference and we can see where the gingival margin is compared to after healing, we can see that there's been a coronal creep of the soft tissue. And this is very thin soft tissue, but we can see that there's been a coronal creep of this tissue. Why? Primarily because we have volume, we have bone, and we have followed the principles of ideal prosthetic crown contours. So we can control where we want the soft tissue to be. So we're very pleased that at 4 months, we've seen an optimal healing in this case. Once removing that crown, one can argue, should we be removing crowns and replacing crowns on and off all the time, breaking hemidesmosomal attachment? Potentially not. However, I did remove the crown at this point, and we can see a beautiful S-line curve. And we can see that the soft tissue filling in that S-line curve there very, very nicely. And so this is just a mirrored image showing the case on your left-hand side before, and a mirror of the implant crown on the right. And once again, I'm a periodontist. I don't do any final restorations. I send them back to their clinicians for restoration, but these are my provisionals. So this is a provisional that the patient kept for 6 months. And then we can see after 6 months how beautifully the soft tissue is healed around that crown. And I think at this stage, the patient and the restorative clinician has a much easier task of restoring, and our job here is done. Thank you.
Recording stopped.
Okay, thank you for your presentation.
Thank you so much, Dr. Cornell, and everybody else listening. I appreciate your time once again. Thank you for all the late nights. It's nearly at the end of the continental round, so you can all have a rest soon.
Okay, judges,
Thank
any
you.
comments? Yeah.
Great medical documentation. Congratulations. I have one question. How long you have
Yes.
been using this technique? How long?
How long have I been using
your
Socket
practice.
Shield?
Yes, in your practice.
I've been using Socket Shield for about 5 years, Doc. And if I'm honest with you, I can say that if I look at the best aesthetic results I've got, it has been with Socket Shield. Some of the worst complications and failures I've had have also been with that. That is my experience. It is not the opinion of many of my mentors and others alike, but certainly I find that when it works well, it is time consuming, it is technique sensitive, and it requires a lot of attention. When it does work, I find that it works very, very well to maintain. Of recent months, probably the last 6 months, I've probably seen a couple of cases with passive eruption of the root shield through the soft tissue. And because we always create the prosthesis to be clear of any root shield, there's nothing actually maintaining that root shield in place. And so we get this, spontaneous passive eruption of the root. And then it becomes a problem because then we'll end up taking the crown off, and now we're taking the shield down, maybe doing a connective graft, putting it back, praying and hoping that everything works out. But then in a few months, that same patient is back. And I think it stems from the problem that we don't actually know if there's a functional ankylosis of that root at the time. If there's true ankylosis, there won't be eruption. But certainly in some cases there aren't. So it's a learning curve, and I've had good success with the Socket Shield technique. It is time consuming, and I do use it myself. Is it easy? No. But I've also had some unfortunate failures with it, and I need to be honest about that. So I hope that answers your question.
Super. Thank you very much.
Dr. Garrana, you have very excellent result.
Thank you.
As a Cornell and me, we have some possible issues in our country. For example, if you would perform the Socket Shield technique, and if it goes something wrong, the patient would go to the court, and it would be claimed that you left the foreign body in the socket.
Absolutely, absolutely. So, these are challenges. These are challenges that we face. I always say it's easy to make the decision yourself to do something, but you always have to think about the patient's experience. And if I have to be honest and say to you, the patient, I'm more worried about 1 millimeter of tissue than most patients. But for the risk that I'm taking to get a perfect outcome, is it worth taking that risk all the time? So I'm very selective over the cases that I choose to do Socket Shield. To be honest, the cases that I choose, I know that there's adequate bone volume palatally. I know that I can get the implant sufficiently palatal. If I can see that the implant's going to be close to the shield, perhaps it's not a good option, because if there's not enough space, the bone fill there cannot be ideal. And if there's no bone, then you've got a potential for a complication. So I don't always get it right. To be honest, there's a lot of times I don't get it right. I often say, if only my good cases made up for the bad ones, I would be a much happier clinician. But they don't always. We get most of them right, but some we get wrong, and we have to try and learn from that. So certainly, it is a higher risk procedure. It takes more attention. It takes a little bit of, I wouldn't say maybe for a beginner implantologist, maybe not where you want to start, but I have achieved good results and with it. And it's something that I would probably continue to use until the data proves that maybe I shouldn't, and we change. But for now, I do see a benefit of it in some cases.
Yeah, you're absolutely right. And if we consider dentistry as a science, as our specialization and as a business, and of course, if you're older you are getting, and you so more aggressive you go to the business, of course, the stockage technique will be a little bit really it could disappear from your practice. If you have a lot of time,
Absolutely.
you can
I mean,
develop perfectionism and perfection, and of course, this technique, science-based work, and of course, it works in good hands. And you demonstrate also excellent results and also very good photography skills.
My name is Dr. Ahmad Alanezi. I am from Kuwait, and I'm very pleased that I'm going to present this lecture to you this afternoon. The title of today's lecture is Rehabilitation of an Edentulous Patient in the Digital Era. In this presentation, we will discuss what are the thought process that we take in order to reach a digital planning and execution during an implant treatment, as well as discuss what are the surgical and the prosthetic aspect that the digital technology will help us in. Before we begin, my name is Ahmad Alanezi. I'm from Kuwait. I graduated from Mohammed bin Rashid University and did my prosthodontics training there, as well as joined Harvard School of Dental Medicine to do an implant residency. In this case, I'm presenting, that was during my residency in Harvard School of Dental Medicine. In order to, before we jump into the case, we need to define what is a complete digital workflow. Usually they are divided into 5 stages. And the first stage, and it's the most important stage, is the comprehensive evaluation. During this stage, you really want to have a global analysis of the patient. You want to know the patient dental, your patient occlusal, and periodontal evaluation and assessment. You also want to have a good radiographic analysis. You want to know whether the patient is candidate for dental implantology or not. You want to know the risk factors the patient possess when you design or plan this kind of treatment. And after done a thorough evaluation, you can move into the data acquisition phase, which is mainly digitizing your patient. And the way you can do this with the 3 tools. One is a complete CT to get your DICOM file, and then the second is an intraoral scan, and the third will be a 2D photograph or a 3D facial scan. After having these data, you will be able to perform a virtual planning. During the virtual planning phase, you will be able to superimpose these data together, the DICOM with the iOS file. You'll be able to know what type of implant you're going to place. You're going to know the diameter and length, and most importantly, you'll be able to know the virtual abutment before you even start your surgery. You'll be able to design your guide, and then once you design your guide in the virtual planning, you can move into the CAD/CAM technology, and it can be either milled or printed, and you can mill or print your prosthesis or your guide, and you'll be able to perform your guided implant surgery. Let's jump to the case. This patient, he came to the clinic looking for a second consultation. He's a male, 30 years old, relatively a very young age, and he wants an implant teeth. The patient medical history revealed that he has trichomalacia, and trichomalacia is a condition where the trachea is actually deficient. It cannot clear the fluid or secretion from the lung, and this is especially important when we are designing our denture, because sometimes the denture can accumulate some of the mucus, and the patient reported that his previous denture accumulated mucus and made him have a coughing attacks, and those coughing attacks sometimes developed respiratory illnesses and pneumonia. So we wanted to know that the denture that we wanted to know how good of a candidate the patient is for a complete denture, because it's also one of the main things that we rely on when rehabilitating an edentulous arch. Okay, a series of extraoral photographs, and these are very important photographs. What we wanted to know is we wanted to see the overall facial features of the patient, and we also wanted to know that if the patient is exhibiting a lot of ridge when he's on a full smile. Let's say the patient is exhibiting a lot of ridge, maxillary arch ridge showing, then you know that from the get-go that this patient is a candidate for a ridge reduction. And why I'm saying this, I'm just like talking to you into the thought process, what we do when we are planning a case like that. Facial analysis is important. We found out that the lip support to the nasolabial angle here is within 90 degrees, which is without the prosthesis, so which is a good number. And this is the patient intraoral situation. We found out the patient is edentulous in both upper and lower arch. The patient is having a large tongue space, which is a diagnostic feature, knowing that your complete denture may not be retentive if you put it as interim prosthesis. Also, the patient is having high muscle attachment. The occlusal view, you find out that the upper arch is well developed with the oval arch shape. The oval arch shape also is a diagnostic feature to know how many implants you're going to place and where are you going to place your implants. And there's a good band of keratinized tissue, which indicate that you may be able to go with a flapless approach here. The lower arch is also the same, that there is a presence of high muscle attachment. However, if you pay attention to the anterior aspect of the lower arch, you find that there is a lack of keratinized tissue, especially on the buccal aspect. And this is especially important because if you are planning for a flapless approach, you might not want to do it in this case. You want to open a flap and then place your implant and then cover it up, or to not lose this kind of band of keratinized tissue. The treatment plan were given to the patient, and the patient chose implant-supported fixed prosthesis. And because the patient chose implant-supported fixed prosthesis, we need to first design a diagnostic denture. And this is this is the most important step in your planning, is designing a good diagnostic denture that have a good occlusal scheme as well as representing good facial features. And this is the patient wearing the denture. And then we also wanted to evaluate the interopupillary line with the incisal plane line, as well as we wanted to know whether the midline is in the center or not, because this denture will serve as a prosthetic template for your implant planning for everything that comes after that. Not only we did the denture, we did the flangeless denture as well. And we wanted to know the incisal plane, you wanted to evaluate the lip support and the teeth display and the buccal corridor. And once we are happy with this, we can take those dentures and put them in a dual scan protocol, as discussed earlier from our previous colleague. We need to put the fiducial markers in our dentures and perform 2 sets of scans. As the name suggests, it's a dual scan protocol. The first scan will be from the denture itself, and the first scan will be the denture itself. The second scan will be the patient wearing the denture. You want the patient to occlude, okay, rather than put a cotton roll. So you have the upper and lower together, as well as after acquiring all these data, you can import this information and put it in your virtual planning software. So you can use this diagnostic denture in order to plan your implant and to plan your future prosthetic and your surgical guide. This is the virtual planning. This is the initial situation after we had all these data imported. This is the approved denture that we discussed earlier. And this is the new prosthetic that we made, because in this case, we are going for an FP1 at the top and FP2 or FP3 in the bottom. We also wanted to make sure that the occlusal scheme in this kind of situation is either canine guidance or occlusal function or group function. And this an article by Professor Humley Wang suggesting that, you know, with each implant fixed prosthesis, you have a different type of approach. So I suggest that we, if someone is interested in what kind of occlusal scheme should be done for his patient, to look at this lecture. There are a set of series or questions that I need to ask myself when I plan an implant case. And one of them is, what is the implant design I'm going to use? And in this case, I wanted to use an aggressive thread implant design. And the reason for that is because I wanted to ensure high torque or a high insertion torque during my implant placement, as well as I wanted to load my prosthesis on the same day of surgery and have the patient leave out of the office with a prosthesis, with a converted prosthesis. And we have strategically chose this kind of implant, and many thanks to Megagen for, you know, being a pioneer in this aspect with the annuage design. We also wanted to know how many implants are we going to place. In the maxilla, we decided in 8 implants, while in the mandible in 6. The reason why we decided 8, because the arch is oval, and we also wanted to do a segmented prosthesis rather than splinted, especially after knowing the patient is in a young age. So if down the road, as we all know that implant prosthetic, they have complication in 5 or 10 years. So if the patient have a complication in one segment, we can remove it and we can repair it rather than removing the whole thing, and repairing the whole thing will be much costly. The prosthetic abutment, we are going to have our prosthesis on the multi-unit. We don't want to go direct to the fixture, and the reason for that, we don't want to disturb the peri-implant mucosa in that area. And I'll show you an article by my program director, Dr. Gulucci, saying that different type of abutment design will negatively impact the marginal bone loss around it. The final prosthetic design will be FP2 in the mandible and FP1 in the maxilla. The final prosthetic material will be monolithic zirconia, and the type of the prosthesis, as we discussed, segmented in the upper and splinted in the lower. And this is a paper that we I collected saying that, you know, when you are planning for an immediate implant placement and immediate provisionalization, the biological and prosthetic complications are rare. But I would read this and caution that, knowing that you have addressed all the risk factors beforehand. And this is another article. It's a histological and micro CT analysis of changing the healing abutment or for the implant. And they found out that they influence the marginal bone loss. So if you have an abutment one time, the risk of having a bone remodeling around the neck of your implant is much less. This is a virtual mock-up, so we superimpose everything just to make sure that everything is in place, because now we will rely on this mock-up to design our implant, to design our guide and everything. So this is the maxillary arch, and we have placed all our implants, and we have strategically chosen their position because we are going for a segmented approach. We placed our implants facially driven because we relied on the face, as well as prosthetically driven. We selectively chose our abutment, the prosthesis type and the design, and we were avoiding the vital structures when we are planning. Same thing in the mandible, and I want to show you like how the SRA are virtually selected. So during the surgery, you don't have to waste or use multiple SRAs just for a single site. That was one of the main benefits of having a virtually selected abutments. And this is the upper and lower. We knew that in size number 14, we're going to go subcrystal sinus approach, and size number 3, our implants are fully placed in the best position possible. And we were able to select our implant height and width, as well as we were able to select the virtual abutment and corresponding to the prosthetic plan. That's a lower arch as well. And in this case, we decided to go with sequential guide. Also, they called it as a pin-supported guide. So use the denture with a pin on the denture itself. And these pins will serve as a common reference between the next two guides. And then after having the fixation pin guides, then we can place our drill guides and then the guided prosthetic, as I will show in the next slides. So this is the fixation pin guide on the day of surgery. And this is a mucosa supported guide just to place our fixation pins. But we also have to realize that we need to replicate the occlusal scheme of the guide, both in the denture. It should be similar to the prosthesis that you are to the guide that you're making. And this is the anchoring pin placed. And what I want to tell you here, that if you are placing anchoring pin, you want to go left, then right, then middle, instead of going one side to another. Because if you go from one side to another side, you will introduce a lot of inaccuracy. And you will be able to have your guide as planned in your virtual plan. Then you move into the next guide, which is the drill guide, and you put your drill guide. The difficulty here, sometimes the mucosa act as a barrier, so you'll be struggling placing those pins. And the solution for that one is to place the pins in attached mucosa rather than in non-attached mucosa or keratinized mucosa. And the second is to increase the number of pins as much as possible, but make sure the posterior pins are facially placed, so you can easily put them and remove them during surgery. Our implants were drilled in a fully guided fashion. We have a surgical protocol guide. This will serve us as a guide or a template, but you don't have to follow it because, during the surgery, you might run into weak bone or a strong bone, and it might be different in case by case. And this is our implant, fully guided, placed. This is our multi-unit and multi-cylinder placed and torqued. And you can see that our temp cylinders are exiting from our predetermined channels, which means that we are succeeding in this execution. This is the prosthetic, and this is the day of the surgery, and this is the patient leaves on the first day. Next week, the patient comes, similar procedure applies. The only thing in this that we had to open a flap in the lower to preserve the band of keratinized tissue. We placed our multi-unit abutment. We made sure that I have enough space around our multi-unit abutment. Our temp cylinders were also placed. Our prostheses were placed and picked. And as you can see, they are exiting from our predetermined channels. Then this is our prosthetic, and this is how the patient have his prosthesis on the same day of the surgery. And this is the post-op OPG. Then couple of months after, 3 months after, the patient comes for digital impression and a CAD/CAM designing. Then this is how eventually the patient started with, and this is the patient how he left, and we wait for another 3 or 4 months for the patient to test drive those prostheses. That's our OPG. This is our patient again, thoroughly. And with that, I would like to thank you so much for your time and for your attention. I'd like to thank my faculty for their support and helping me throughout this case. Thank you very much.
Recording stopped.
Okay, thank you for your presentation.
Thank you.
So, okay, so judges has comments.
Thank you very much, doctor. It was great presentation. I showed everything what I want. Fantastic. Thank you very much.
Thank you.
Okay, so the result will be announced.
Good evening. First, I'd like to welcome the esteemed judges and any other audience who are watching us today. Let me introduce myself again. I'm Dr. Wala Al-Bastaki from Bahrain. And today I'm going to present a case that is 3 implant placement in the maxilla with external sinus lift. A very young, beautiful lady, she was only 26 years old, attended in my clinic. She did not like her smile and she wanted to improve it because she had multiple spaces due to previous extractions and remaining roots due to badly broken, untreated caries teeth. Generally, she was in a healthy condition, no medical disorders. She's not taking any medication. She has no allergies, no family inconspicuous. So as a total, she did not have anything that contraindicate implantation. She had good general and nutritional condition, adequate weight and height. Extraoral examination was done, inspection and palpation without anomalies, function of the facial nerve unrestricted, and both sides look identical. Here are the intraoral photos of the case. Maybe the first look you see the photos, you notice how challenging is the case from the mainly the prosthetic point of view, because the interocclusal space between the arch is very limited. So this is something very important to consider. Putting an implant without being able to restore it properly is useless. We can see that she has multiple spaces due to previous extractions, remaining roots due to untreated caries teeth, failure in some composite fillings, moderate calculus, and in details, let me see. Teeth condition, missing teeth 2, 5, 3, 6, and 4, 7. Remaining roots 1, 5, 2, 4, 2, 6, and 4, 6. Badly broken tooth 1, 8. Composite filling in teeth 1, 1, and 2, 1 with recurrent caries. broken composite filling in tooth 1/6 with recurrent caries, untreated caries in teeth 1/7 and 3/7, rotated teeth 3/4 and 4/5. Soft tissue condition, swelling and inflammation in the papilla due to generalized gingivitis. Bone condition, generalized horizontal bone loss, no enough ridge height for implantation in the upper left quadrant. I will show you this in the coming panoramic radiograph. Relationship of the jaws, class 1 incisor on skeletal base. Class 1, deep overbite with limited interarch space, as mentioned previously. We had moderate calculus in the lower anterior segment, generalized gingivitis, and loss of papilla due to poor oral hygiene in some areas. Here is the panoramic radiograph. I believe that I had to put this panoramic radiograph bigger a little bit. Sorry for that. It confirms all the intraoral findings we mentioned, and it also adds that the upper right first molar is root canal treated, and it also shows the limited height of bone in the upper left quadrant. Here are the study models of the case. As a diagnosis, we have missing teeth 2/5, 3/6, and 4/7 due to previous extractions, remaining roots of badly broken teeth due to untreated caries 1/5, 2/4, 2/6, and 4/6, badly broken and non-restorable tooth 1/8, composite filling with recurrent caries in between the central incisors in the upper arch, broken composite filling in tooth 1/6 with recurrent caries, caries in teeth 1/7 and 3/7, rotated teeth 3/4 and 4/5, moderate calculus in the lower anterior segment. We put a general treatment plan that includes everything, and then it's the patient call to decide what she prefers to do. So I wanted to start with oral prophylaxis, scaling to remove the calculus and improve the periodontal condition, extraction of the upper right wisdom tooth and the remaining roots 1/5, 2/4, 2/6, and 4/6, redo the composite filling in tooth 1/6, followed by zirconium crown to protect it because it was root canal treated, redo composite filling in teeth 1/1 and 2/1, filling in teeth 1/7 and 3/7, then orthodontic treatment to improve the bite and adjust the rotated teeth and crowding of the upper arch. Implantation to restore the remaining space after orthodontic treatment. Gingivectomy to improve the gummy smile, or let me say gingivoplasty in some areas. Veneers to adjust the shape of the anterior teeth. If it was me, I wouldn't propose the veneers, to be honest, in her case, especially that she's very young. But because the first word the patient said when she walked into my clinic, "Doctor, please, I don't like my smile. Please change it. I want Hollywood smile." This is the mindset she came with. I told her it doesn't go this way. You have lots of things to treat first, then we can do what you want. But sadly, after proposing all this to the patient, she actually refused to follow all the steps of the treatment plan only for economic reason. And she wanted to do implantation to restore the upper left side to improve her aesthetics and function. Based on this, we started our treatment on April 29th, 2022. We did our measurements on the panoramic radiograph. You can see the limited height of the ridge in the upper left quadrant. So we have no enough ridge height, and we decided to do sinus left through lateral window technique. Bilateral mucosal flap was raised to reach the maxillary sinus through lateral window technique. Maxillary sinus was elevated. I'd like to apologize for the poor quality of this photo. It's the best photo I found in this case. Sometimes it's difficult to do retraction, control the bleeding, and take very good quality photos, especially in technique-sensitive procedures. Anyways, remaining roots 2, 4, 2, 6 were extracted, and implantation was done immediately to replace the missing teeth 2, 4, 2, 5, and 2, 6. Bio-os sponges granules were used to fill the area after the sinus left, and the bone graft was covered with osteobial resorbable membrane. And the flap closure was done with continuous sutures. This is a panoramic radiograph taken immediately after the surgery. Going to our surgical notes, date of surgery, as we said earlier, April 29th, 2022. The duration of the surgery was 2 hours because I needed to elevate the Schneiderian membrane with care. If we did not have the sinus left, it wouldn't take more than 45 minutes. Number of implants placed, 3. Implants location, 2, 4, 2, 5, and 2, 6. Implant diameter and length. I placed same size of implants in the 3 areas. We managed to be able to put 11 millimeter implants after elevating the sinus. Implant diameter was 4.2 and the platform was 4.5. Osteobial sponges granules 1 to 2 mm was used. Osteobial resorbable membrane and implant system was SPI Thomann Medical. This is the situation 6 months after implant insertion. Usually I do the surgery and I see the patient after 2 days just to make sure that he's fine. Look at the sutures, check the wound, make sure that he's not having any complications, everything is under control. And then I see the patient again after 14 days to remove the sutures. Although the sutures used here are absorbable type, but I believe that after 14 days, they are useless to be there. Even if they are still there, I remove them because they start to be loose and annoy the patient, and food will start to accumulate on them. So I believe that they are useless after that, and I remove them. And then I schedule the patient accordingly. Depends if I want to see him after 2 months, 3 months, 6 months. In this case, I brought the patient back after 6 months, and I will do stage 2 surgery because, as you see, the implants were submerged. Because I can see clearly the covering screw of the implant, so I decided to expose the implants using diode laser to make it just a neat cut around the covering screw and to avoid having lots of bleedings and faster recovery and healing, you know, the magic of laser, I believe. So the implants were exposed using diode laser and the gingival formers were attached. This is the situation 2 weeks after implant exposure, ready for the final impression. I love the gums, to be honest, the pink aesthetics. It looks amazing. This is the impression copings in the patient mouth, and I'd like to take always intraoral radiograph confirming the correct position of the impression copings to the implants. Final impression with the implant analogs 2 weeks after implants exposure. And here are the screw retained abutments and crowns seated in the master cast and ready for delivery 7 months after implant insertion. As a personal preference, I personally prefer screw retained. I'm a fan of screw retained prosthesis. In this case, due to the challenge of the space, I'd rather have the screw getting loose every now and then. If I'll have to choose between the disadvantages that I might face, I'd rather choose the crown, this getting loose, than the patient coming with the crown in her hand every now and then. And also, I personally prefer to have the crowns individual. Most of the paper says connect them to increase the occlusal table for the forces, but I like to give my patient chance to floss and clean properly between their crowns. This is the emergence profile 7 months after implant insertion, ready to receive the screw-retained abutments and crowns. I believe that the gums are very healthy. They look amazing. And this is the occlusal and lateral view with the crown seated in the patient mouth. Intraoral radiograph confirming the correct adaptation of the screw-retained abutments and crowns to the implants. This is the final restoration seated in the patient mouth, done 7 months after implant insertion on 20th of November 2022. And this is the panoramic radiograph taken in the same day. After that, the follow-up photo taken 1 year and 6 months after implant insertion. Everything looks amazing and healthy. This is the intraoral radiograph, also taken in the same day of the follow-up. And this is the panoramic radiograph. As a conclusion, the patient was a 26 years old female. We did implants to replace missing teeth 2, 4, 2, 5, and 2, 6 with external sinus lift. The patient is on recall program. Implantation site is stable. Good prognosis is expected if proper hygiene will be maintained with routine visits for oral prophylaxis. Thank you so much for listening, and I really hope that you liked my case. Thank you.
Recording stopped.
Well, thank you, doctor.
Thank you, dear.
The
Dr.
judges, any
Malla,
comments?
thank you very much for your presentation.
Thank you
May I
so
ask
much
you
for
a
listening.
question?
Yes.
If you performed the external sinus lift, why you have chosen short implants?
I believe that 11 mm would be a good length of implants because the latest articles I've been reading, usually they are trying to go away from the very, very long implants. I believe 11 mm would be good in her case.
Because you have so much bone substitute material in the sinus now, and comparing the length or volume of the material and the length of the implants, you have a lot of materials above your implant. So
Okay.
what is the reason for
I thought
that?
it was just to support the implants and cover them.
But what's the reason that so much material above the implant?
Because the membrane was elevated, so I wanted to fill this area.
Okay.
It's not inside the, yes, the Schneiderian membrane was up. I kept the implants. The implants were seen outside the bone apically and outside the ridge, and then I wanted to cover them.
You know, I know if we go back to the OPG postoperative,
Yes,
can you show the OPG?
sure. This one?
No, no, with the crowns.
Yes, sure. Do you feel that I over grafted the area?
Yes, it looked like they. Oh, you can see here. It's a lot material, a lot of.
Maybe I'll have to consider this in the future.
Yes, if you graft a lot, so you should choose the proper size of implant, because there is no sense then.
Okay.
Thank you very much for your
But
presentation.
because in the preoperative X-ray, I couldn't even put the 11. I had some areas of 6 mm. But I will consider this in the future, definitely.
Thank you very much.
Thank you to you.
Okay. So thank you for today.
Thank
And
you.